Okay, cool. So today we have Tony Corner, orthopedic surgeon, with us today. We thought it would be really useful to get him on the call and talk about some of the stuff that we do in the clinic and things that he does as well. We work pretty closely together with some of our patients. Some of our patients end up seeing Tony, and likewise, some of Tony's patients end up coming back to see us. So if you don't know who I am Rhys Carter. I have a physio practice in Hoddesdon, the Carter and George practice, which is a multidisciplinary practice. We see all sorts of people from sports athletes all the way through to people with back pain, neck pain, shoulder pain, and which kind of brings us onto this because Tony is a shoulder and elbow specialist. So to start with, Tony, talk to me, tell everyone who's going to listen to this who you are, what you do, and maybe about how you came to be where you are as the shoulder expert that you are.
Many thanks for that very kind introduction, Rhys. I'm Tony Corn. I'm a shoulder and elbow specialist and consultant orthopaedic surgeon who practices out of Spire Harpenden Hospital, Spire Bushy Hospital, and also One Stop Doctors private hospital in Hemel Hempstead. I originally came from Liverpool, as you may tell from part of my accent, and I studied at St Mary's Hospital Medical School in London, which was then formed part of the Imperial College School of Medicine. After qualifying in London, I did all my basic surgical training in and around London and home counties, and then after fellowship training, whereby I sort of trained at one of the leading shoulder and elbow in the UK for a year, learning complex reconstructive techniques. I was also sort of honoured to be awarded the British Orthopaedic Association European Travelling Fellowship. So I got to learn some shoulder surgery from 4 of the world's leading shoulder surgeons in France, Italy, and then lo and behold, I end up here in sunny Hertfordshire, sort of practicing as the Tony Corner Shoulder and Elbow Clinic. And I've been a consultant now for just approaching 10 years, so I'm approaching my decade. And I've learned a lot of things along the way from a lot of excellent sort of colleagues and mentors. And hopefully, you know, I put that into practice every day in the patients that I treat. And I treat everything under the whole spectrum of shoulder and elbow pain, from sort of chronic conditions to more acute sporting injuries or traumas. The vast majority of the work in the shoulder is chronic conditions. Indeed, shoulder pain accounts for approximately 2.5% of all GP consultations for musculoskeletal pain. So there's a huge pool of patients out there in the community who sadly suffer shoulder pain every year. And I think the first part of my job is to help sort of, you know, achieve the correct diagnosis.
Yeah.
And many people think that by seeing a surgeon, you're naturally going to be talking about an operation. But in actual fact, I only operate on approximately 1 in 5 people I see. Yeah. And I think the prime aim of my job is, rather than be seen as a shoulder surgeon, I'm more of a shoulder specialist, so that I can help get the right diagnosis and then work closely with people like yourself, Rhys, and your team at Carter and George to then formulate the correct plan and get the patient on the right treatment path.
Yeah.
It just so happens that because I'm a surgeon, if the patient requires an operation, which is the right thing for them to do, then I can provide that skill set.
Yeah.
But even then, it's still crucial to liaise and work closely with people like yourself so that we can optimize the patient's outcome following any surgical procedure that they may undertake.
Yeah, I mean, that's a good point, actually. One of the main things that physios like about orthopedic surgeons is the ones who do less surgery. So I think actually one of the main reasons that we kind of start working together is because we can trust that, you know, we're not going to send someone in who potentially doesn't need surgery, just needs a consultation or needs something like a scan or an injection, and they end up coming back in a sling after surgery. And, you know, unfortunately, particularly in my background working in the Middle East, that was quite common. And it's good kind of to have that trust that, you know, you're not sending people away and they're kind of condemned to surgery, whatever's actually wrong with them. So that was kind of one of the key things that we look at as well.
I think what I would say is the majority of shoulder pain and other conditions which cause shoulder pain settle down without the need for an operation.
Yeah,
and I like to think that it's key to sort of exhaust the operative measures first,
Yeah.
and to assuming that those non-operative measures are being guided towards treating the right diagnosis, because so often I see patients who've had sort of treatment which then isn't actually for what I think is the real cause for their pain. And then once you get them on the correct treatment path, they invariably get better. And there's only sort of a small amount of indications where a patient needs to go straight for surgery. Obviously, quite often that's related to some sort of traumatic injury, rather than any sort of chronic pathology.
Yeah, it's true. It's just one of those things. I think that diagnosis, in terms of what we do over at our place as well, it sounds obvious, but it's so important about guiding the plan about what actually the kind of scale of treatment looks like, because there are certain things like, when you get people in who've been diagnosed with a rotator cuff issue, if we're talking about shoulders, and actually it's a frozen shoulder, and all of a sudden the timescales are significantly more, and the likelihood of success in the short term is much lower. And it's about managing expectation and making sure that person actually, once they know what the problem is, it's much easier to kind of get them on board with what's going ahead. But
Yeah,
diagnosis,
I think also as a surgeon, it's also sort of important to give patients reassurance at the right time. I think a lot of patients feel inhibited. They feel very anxious about using their shoulder, particularly when they're recovering from an injury or recovering from some sort of surgery. And I think an important role for the surgeon is, if it's appropriate, give the patient the reassurance and confidence to engage further with the therapy, to sort of push on with their rehabilitation.
Yeah, for sure. I mean,
and disinhibit the patient.
I mean, what we would say in our place is that, if you think probably people end up in for physio for shoulders, the vast majority of them are related to a tendon pathology. And, probably the worst thing you can do is to not use it. I mean, we're big believers in trying to load it heavy and gradually, and just try to start to strengthen is super important. We sometimes talk about tendons in our practice to our patients about how actually they are a unique structure, in that you could rest it for 10 years and it might not get better unless you start loading. So actually, and that kind of ties into what we both kind of work with together. Okay, so we could talk about shoulders forever. If I had to say, what's a typical week or a day in your office? I know you do different days, you do different things, but talk a bit about what your kind of typical life is as an orthopedic consultant.
I think sort of clinically, and also from a research point of view. I mean, obviously there's the sort of outpatient clinic side of my sort of practice, and that will not only be sort of outpatient clinics face to face, or in the current COVID world, sort of telemedicine consultations. But there will also be sort of reviewing radiology scans. I also conduct a regular multidisciplinary team meeting with my radiologists. So if there's some specific issue, or occasionally I get, sort of quite regularly, some complex patients or second opinions, and it's always, it's good. I have a team of trusted musculoskeletal radiologists who I work closely with, so that we can go through the finer elements of some of the scans to put some more meat on the bones of the actual report. And then I can make sure that when I'm scan correlates well with the radiologist, and also correlates with the real sort of verbal opinion of my team. So there's that side from a sort of a clinic point of view. There's obviously the operative side, in terms of theatre, which would be sort of before COVID, I would normally sort of operate for an entire day once a week, in terms of a routine sort of operating list. And again, I'm fortunate that I've worked with my same anaesthetist for the last decade, who's fantastic at doing interscalene blocks. So we can run a sort of a safe, productive, efficient theatre list. There's also the other side that I think a lot of people sort of don't quite see, in terms of sort of research, is that I'm, for example, an editorial reviewer for scientific papers submitted to Shoulder and Elbow Journal. So obviously some of my time, that is sort of a flexible in terms of the amount of time I'm committed each week to doing that, or the number of papers I'm reviewing, or any other research projects. And also teaching. I love teaching. I'm part of the Watanabe group, which is a group of shoulder consultants who we've been together a number of years now, and we run 2 courses a year, doing a cadaveric course teaching other senior trainees and consultants how to perform arthroscopic reconstructive techniques in the shoulder.
Yeah.
So that's other stuff which we sort of enjoy. And then, of course, we've got the good old conferences and general meetings, which obviously are a bit on the back burner this year.
Conferences.
Yeah, the very, very educational conferences. Yeah.
Really no fun had at conferences. With that, it's actually a good point. I mean, I think staying up to date with kind of recent research and things that are going on, definitely from our clinic, we're pretty keen on making sure that we kind of set ourselves a goal of being at the very top and forefront of what we're doing. And I think that's important. Yeah, healthcare and medicine's changed extremely quickly in the grand scheme of things, and particularly like non-invasive procedure. I mean, my dad, for example, he had a decompression for people non-medical people, just a bit of a kind of a clear out of his shoulder and free up a bit of space in there. And I mean, now that that's a pretty routine standard quick op under either what. Do you do that under blocks now?
Yeah, you can do that under blocks. Absolutely. Under blocks or a quick GA, depending sort of on the patient's preference.
Yeah.
And indeed, in the current COVID climate, in my practice, when we get back to more routine operations, we're going to do more and more under interscalene block and a whiff of sedation, rather than have the patient ventilated under a general anaesthetic.
And people who don't know that's pretty much they're completely conscious and being able to interact with you while you're doing it.
Yeah, so what will happen is my anaesthetist uses an ultrasound machine to then be able to see where the nerves are in the base of the neck in an area called the plexus. And it's like a spaghetti of the nerves that then form the nerves that go down the arm, which work the muscles and also sense any pain. And that informally, then you essentially can perform most shoulder operations with the patient completely awake. And if you're doing that as a keyhole procedure, then the patients can even watch what's going on inside their shoulder on the screen.
It's amazing that happened. I mean, my dad has a scar about 6 inches across the front of his shoulder where he had a relatively routine op about 25 years ago. So, it's all improving. Okay, what if someone said, what is the most kind of hyper specialist thing? If you could pick someone to come in to your clinic who you're a specialist in that particular injury and you get a great result with, what would it be?
I think one of the most challenging group of patients are patients who have had some sort of shoulder replacement previously, and that has failed for one reason or another, and then needs to be revised, because there's a whole spectrum of problems as to why did the patient have the arthroplasty in the first place, in terms of the shoulder replacement. What led to that shoulder replacement not working out? Were there technical issues? Is it bad luck of the patient? Is it something to do with the implant, something to do with the anatomy? Has there been a traumatic event? And then sort of having to work out, you have a patient who's been through an awful lot before, they've already been through a major operation and a long period of recovery. Then they've gone through a further period of discomfort and poor function, sort of staring down the barrel of having another major operation, more recuperation, and with a procedure that will have an even higher risk profile in terms of potential complications than what it was first time around. So I think they're a particularly challenging sort of group of patients, really.
Yeah, fine. I mean, again, shoulder replacement is not massively common compared to a knee or a hip, so it requires a very specialist approach to that. I know actually a family friend of mine's had one, and she had it many years ago, and I think she's made do with the fact that her arm moves about 25% as much as it should be. I probably should send it to see you.
Absolutely. I mean, shoulder replacements, obviously, we don't do anywhere near as many shoulder replacements in the UK each year as what we do hip and knee replacements. It's nowhere near as common. But I think over sort of recent decades, there's been sort of an explosion in terms of the range of implants, our understanding of the shoulder anatomy and shoulder biomechanics, which has helped further develop and fine-tune the type of shoulder replacements we insert. Even sort of the sort of development of reverse arthroplasty, where we put implants in deliberately the other way round to change the mechanics in the shoulder. There's lots and lots of different technology, and even now, with the guidance of computers and preoperative planning, we're learning much more and developing even finer techniques, such as instrumentation, to help guide exactly where we should put the implants and prepare the shoulder in order to insert a shoulder replacement into just the right place. So technology is really moving on, and it's quite an exciting field actually now.
And obviously with that has come a greater success of an operation that had previously had a relatively high failure rate.
Yeah, it's prep. Any operation is about preparation. Prepare poorly and then prepare for failure.
Yeah.
It's all about the preparation. It's as simple as that. If you want good performance, good outcomes, it's all about the preparation beforehand, executing the operation, technically as well as you can.
Yeah.
Like with any operation, you cannot exclude and eradicate all the potential complications down to 0%, but you can try and push everything as much as you can humanly possibly do to get all the risks down as much as possible. And by embracing technology, then obviously that's the next step forward.
Yeah, that's great. Okay, so if we flip this and talk about then some more the gory details of shoulders. What's the people ask me this all the time, and I have only I've got some pretty good stories on it, but actually I'm sure as a surgeon you probably see things with even better stories. What's the biggest injury that you've personally had to treat?
I
Shoulder.
think you've got to go down the sort of traumatic route, where and it usually involves our good friends on motorbikes,
Yeah.
Who are ticking along a little bit faster than maybe they should,
Yeah.
and they go over, and then when you sort of combine a really nasty shoulder fracture with also a really nasty elbow fracture, because they may have had multiple impacts, wrap themselves around a lamppost, just an absolutely awful high energy trauma, then usually about sort of halfway through, when you sort of open up various parts of the anatomy, dissected out various nerves, hopefully you've not had to sort of involve the vascular surgeons to do something to the blood vessels, then you piece the jigsaw puzzle of all the bones back together, and usually your trainee surgeon who's sort of operating with you is sort of wondering, how on earth are we going to put all of this back together again? And then you by the time you sort of finished and you've stitched it all up, usually your trainee can't believe you've actually sort of finished that.
Yeah, that's pretty. I think probably the biggest one I saw was a few years ago. I was treating a professional bodybuilder who may or may not have been entering the categories of someone who is not doping, and he was doing an 82 kilogram dumbbell press on a flat bench on each side. As he just dropped it down, the pec completely ruptured off the bone, and the only question he had for me was, if he had to have an operation, would it ruin his aesthetics when it came to posing on stage?
Oh, fantastic.
To which I pretty much responded that the choice was between that or the use of your arm for the rest of your life. It's up to you. But it was.
I do enjoy, particularly sort of, the rugby players. I've had sort of players before who've actually ruptured their biceps.
Yeah.
So the distal biceps, and one of the players actually sort of continued to play.
Yeah.
Scored 2 tries. And then it was after the adrenaline started to settle post-match, he realises the sort of severity of the injury. And then ultimately I go on and perform a surgical repair of his biceps.
Yeah. He's managed to get through the game.
But he actually got through the rest of the game. And this was not just sort of little weekend warrior, it was sort of semi-professional level.
Yeah. I remember Jamie ruptured his distal bicep actually. Just before about 6 months before the Lions tour, I think it was. And I remember him just trying to shake that one off, but not quite as simple as just shaking that one off, unfortunately.
No. And I think a lot of people, I mean, it's interesting when you deal with professional sports persons, there's very much sort of a different sort of spectrum as to how they respond to injuries.
Yeah.
And I think sort of a lot of the rugby players, I think certainly at professional level, I think it's actually quite rare for a player to actually 100% fit
Yeah.
and not have some sort of niggle, some sort of injury. And in many cases, you're trying to keep them ticking along at as best a functional level as possible.
Yeah. Yeah.
Because
It's unique.
because obviously operating puts them out of action, misses game time, misses season time.
Yeah.
You only want to perform an operation if you really, really have to.
Yeah, it's a very unique group of people. I mean, just talking to Jamie, I know he's feeling as fit as he ever has done with this coronavirus
Yeah.
enforced break, basically. And yeah, I think a lot of those injuries in rugby and any professional sport, they are quite a unique patient group. The one thing I would say that in terms of what we do, we find it refreshing with those guys because they do generally listen to your advice and follow
Yes.
your plans. Probably the hardest people we treat are the pretty good athletes who are not necessarily doing it for a living, who don't want to stop. And they're the more challenging ones. In fact, I quite often talk about this. We'll come on to CrossFit shortly, but sometimes I talk about there's a lot of the CrossFit guys I look after just saying that actually you guys train more than professional athletes.
Yes.
But you also have a life where you have to go and get a job and you don't eat as well as them and you don't sleep for 10, 12 hours a day and
Yeah.
all the rest of it that comes in with recovery. So
Yeah.
then for us, they're definitely the most challenging is the not professional, but high level athletes.
I think another challenging group are young athletes
Yeah.
who may be sort of hoping to embark on a career either in rugby, tennis, cricket, gymnastics, swimming. So you not only got a very motivated sort of 16, 17-year-old who's, sort of got one eye on over the next 18 months trying to get sort of pen on paper on some sort of contract or break through into a particular team. You've also got the parents and the family.
Yeah. Yeah.
And I think a lot of the consultation and a lot of sort of the management is also not just the management of the patient, but also having the family on board as well. And that can often be quite a challenge.
Particularly in sports, like maybe not so much kind of off topic with shoulders, but within some of the footballers that I see, kind of 14, 15-year-old academy footballers at Premiership clubs, and a simple injury like Osgood Schlatters, or for those who don't know who that is, kind of a growth related knee injury, which just requires a bit of downtime and some rehab. I mean, the amount of people that just push on for fear that they're going to lose an opportunity at a contract and get discarded from injury through injury is quite alarming, actually. And again, that I think you made a good point about parents. I think parents are quite key in educating and pointing towards a longer term picture.
I think also sort of, on the topic of rugby, if we look at sort of, academy level players and in terms of their size, their fitness, the amount of weights that they can push, and the amount of sort of actual force and power that they can deliver, it's an awful lot different than when I was that age. An awful lot. And these they are so much more powerful than sort of years gone by. And it's no coincidence that if we look at the sort of injury statistics in rugby, it really starts to rise from the age of 16. And these sort of teenagers are essentially as strong as what previously you would expect in sort of students playing university rugby or some sort of sort of semi-pro weekend outfit. They really are sort of big lads, and there's so much more focus on their strength and conditioning, their nutrition. They are big boys and girls.
Yeah, no, there's some big. You should have if you'd gone back 20 years, Tony. You might have stood a chance. You big fella yourself.
I don't think I'd have ever stood a chance.
Fine. Okay, so that's some of the big stuff. Which some of the bigger injuries are obviously not quite as common. What's the kind of typical? What's the most common things that you see?
I think the most common thing is sort of rotator cuff related shoulder pain. There's the old-fashioned term for it would be impingement, which is not sort of strictly true. There's lots of causes of pain now, whether it's coming from actual tendons themselves, is it coming from the bursitis, which is sort of inflammatory tissue around the top of the tendons. Often patients have been told either by the doctors, by the GP, by other therapists, about sort of impingement, and patients often seem to understand that expression as if their shoulder and their tendons are impinging underneath the shoulder tip, and they sort of, oh yeah, I get it now. That's why I get that pain. And despite your best efforts to explain the problems of tendinopathy, bursitis, etc., they still go, right, I think I get you. So basically, I've just got impingement, and you think, okay, right.
Yeah.
So
Yeah.
yeah, so rotator cuff related shoulder pain, it's so common.
Yeah.
And and thank goodness, the vast majority of patients, if they progressively load their shoulder, try and get those tendons as fit as possible, then most people settle down. Indeed, the role of steroid injections, well, if a patient's sort of got a bursitis and that is sort of inhibiting them doing their steroid, from doing their therapy, steroid injections can have a role.
Yeah.
Occasionally, you'll see patients on their ultrasound scan, they've got a very thickened tendon.
Yeah.
And steroid, not only acting as an anti-inflammatory, also helps reduce swelling of tissues.
Yeah.
So there may be not just the anti-inflammatory effect, but a possible mechanical effect in terms of reducing the swelling of the tendon.
Yeah.
But generally, I think it's just important to, try and get that patient, keep them as active as possible,
Yes.
and to sort of load the tendon. But part of that in the initial phase is getting analgesic control.
Yeah.
Because, in my opinion, how ask a patient to go and see their therapist, do a load of exercises when they're just not going to, sort of emotionally and psychologically engage with that unless we've got on top of the pain.
Yeah.
So, a guided injection to the subacromial bursa will help. I think it's also important to point out is that a lot of people, sort of the more mature population, may have symptoms emanating from a degenerate acromioclavicular joint, which is the joint at the end of the collarbone as it joins onto the shoulder tip, and that's called the AC joint. Now, when we're north of 40, we all have a bit of wear and tear of the AC joint. That's part of the natural history of the joint. But some people get quite a well-localized pain to the AC joint area. They may be getting a lot of clicking or grating there, or it may be very tender or much more tender on the symptomatic side compared to the other side.
Yeah.
And they may notice when they're going through a high arc movement that their pain is worse. And those patients often benefit from an injection into the AC joint at the same time.
Yeah. Yeah. You made a couple of good points about that. I mean, two things that we probably really kind of hit home with some of our rotator cuff and AC joint patients. Actually, again, not by any coincidence that the most common patients you see tend to be the most common patients we see as well.
Mm-hmm.
And we would say the same with the steroid. I think there's a misconception about a cortisone injection or a steroid injection is that it just masks the pain. We see that a lot, and what we try to explain is that it is a pain reliever, but it is an very strong anti-inflammatory. And if there is an inflammatory response going on in the shoulder, sometimes that is required to be able to do what we need to do to get the shoulder better ultimately.
Absolutely. I think it's also important that the role of steroid injection is just keep bombarding the shoulder with steroid. That's wrong. But certainly an injection, maybe a repeat injection, is perfectly fine. When you're starting to do sort of more than that, you'll start getting detrimental effects. And then that's not advised. And actually, what I find is that by that, you find that you're not winning. And then it's either that the patient's just too bad and he may benefit from a surgical procedure to try and help things. Or always think in the back of my mind, have we got the diagnosis right? Is there something else potentially going on? And that's what I sort of constantly think of. Could there be something else? Could there be something else? But fortunately, the vast majority of people do settle down. And I think what's important for people who engage with physiotherapy is to not, is to actually stick at it for a bit. I see a lot of patients who I'll say, oh, have you had any physiotherapy? And they'll say, yes, I had a couple of sessions, but it wasn't really working. So and it's like, okay, that's not really in my book a course of physiotherapy. so it's quite interesting to sort of just delve into, well, what kind of physiotherapy have you had,
Yeah.
and
Yeah.
to get some sort of idea about that.
Agree.
And although I'm not a physiotherapist, it's not for me to sort of be an expert on what physiotherapists do. It's good for me to sort of see, well, look, has the focus been more on trying to improve range of movement,
Yeah.
or is this patient who appears to have a barn door frozen shoulder been tying different colour therabands around the door handle and been working on the rotator cuff, but done nothing to try and stretch out and regain their range of movement? So that would be, it's quite important to sort of delineate. I think, from where I come from, getting the right diagnosis, and then if the patient hasn't got better with injections and a good course of physiotherapy, then we start entering the realms of whether a surgical procedure may or may not be beneficial. And what's also good is that if you have an over-aggressive surgeon who then just tries to operate on all these patients, not only is that what I think is wrong, and sort of incorrect practice, I think that that surgeon will also have a higher failure rate and a higher number of miserable patients who've not done well. Whereas if we've sort of whittled a lot of the patients down, I think I've got a much better chance of getting a really good outcome for the patients, because we've tried everything else, and we've now got a good group of potential winners.
Yeah, I think that's important, because if you've, and I think you made a good point about really actually trying the other stuff and ruling out the most conservative approaches. I mean, a patient made this point to me about 6 weeks, 7 weeks before lockdown, and I've never thought about this, and it was so good. They said to me, I said that they had a rotator cuff tendinopathy. I said that the average, you might disagree. I think generally the average kind of healing response time for that is between 2 and 3 months. And he said to me, normally at that point in time, people go, "Oh, really? Is it going to take me that long?" But this guy said to me, he said, "You know what? If you fall over and graze your leg, it takes between 4 and 5 weeks for the scab to heal. So if there's something structurally wrong with my tissue, it doesn't surprise me it takes that long." I never even thought of it like that. It takes so long just for something superficial with no real tissue trauma
Absolutely.
to actually heal, that we shouldn't really expect, particularly with tendons where the focus is so heavily on strength and conditioning and gradual loading. If you go to the gym, you wouldn't walk into the gym and do 3 sets of 10 bicep curls and suddenly expect to walk out like Popeye. It takes 6 to 8 weeks to see that change in the gym environment.
And those patients are more likely to injure themselves.
Yeah.
And I think what we need to get better on is injury prevention.
Yeah.
And the number of people who will just go, right, that's it, I'm sort of back at it, and then all of a sudden they start trying to do sort of couch to 10K, they've gone mad, and then all of a sudden, they're probably coming to you with a plantar fasciitis, Achilles tendon. I've got guys who will suddenly be going to do, as you say, they're just lifting, trying to go heavy weights. And I always say to them, my favorite word is gradual.
Yeah.
Okay. Everything's got to be gradual. Sort of for injury prevention, build things up. When you've had an operation, when you've had that rotator cuff repair, and we've repaired the tendons, we're trying to stitch a torn tendon back down onto some bone, and to get it to heal on the bone, you can't just suddenly start trying to do lots and lots of weight. Everything has got to be nice and controlled and gradually build things up.
The opinion on what gradual is sometimes varies between different sports people and medical people. My idea of gradual was a lot different to a CrossFit athlete who wants to go back and start doing muscle ups and stuff. So
absolutely. And when and that's sort of one of the, I think also in the young population, say for instance, a lot of sort of athletes or gymnasts who not only have problems with their shoulder, but say problems with their elbows. They may have sort of a defect on the cartilage, which we call an OCD, an osteochondral defect. That can be sort of linked to sort of repetitive loading on the elbow joints. So we often see that in gymnasts. And really, the mainstay of treatment, initially, or the most common treatment, is actually rest. And you need you need wonderful discipline from that child, to not do the sport they love, which they're used to training hours and hours a week doing, which has been probably part of the problem which led to the condition. And then the ones who are the most disciplined and really taken on board, invariably, hopefully, fingers crossed, do well and recover well. But the ones who don't engage and don't give themselves just become a chronic problem, and they're never quite right. And that can be sort of a real challenge.
Yeah. Okay. So if we stay on sports for a second, I mean, we generally see a lot of sports injuries naturally from kind of what we do at our clinic. But if kind of it's three kind of sports that we'll go through that I would say in terms of what we see the most common sporting shoulder injuries. I'd be interested to see what you would say the most common injuries of those people are, and generally what your advice to them would be. I mean, I have my own opinions on it as well, but it'd be good to hear what you say. I mean, the first and most obvious shoulder injuries we see are in CrossFit athletes.
Yeah.
We would see CrossFit, typically people training a lot, high volume, and even if they've got perfect form, which a lot of them confess that they do, things like I mean, one of the things we work on a lot with CrossFit athletes particularly is their internal rotation of their shoulder. I mean, most of them have got a very poor range of movement in their shoulders. So we work a lot with that. But firstly, what injuries do you generally see in CrossFit athletes, and what do you do about them?
I think with the CrossFit athletes, the most common injuries are tendon related. They've aggravated the tendons. They may have some tendinopathy. They may have some bursitis, or they may have developed a small tear in the rotator cuff tendon, which has become symptomatic. The rotator cuff tendons are common when you're elderly and over the age of 70, but if someone in their 30s, it's not common to see a rotator cuff tear, and invariably that may well be symptomatic. So I think by far and away the most common is rotator cuff related pain. What I would make a comment on is that patients who may be doing sort of quite heavy weights as part of their routine, they occasionally sort of present to clinic and say, I felt something go in my shoulder. Now, what's gone in the shoulder? Well, it could be a small tear of part of the tendon, or if at the time, say for instance, when they're doing some sort of bench press, very heavy, they may just very briefly partially dislocate their shoulder or suffer what's called a subluxation. And that can damage the tissues which line the rim of the socket, which we call the labrum. And the patient sort of feels, sort of a sudden pain. They may have felt that their shoulder had popped, but it's sort of gone back in place. And that they were then able to sort of go home, they could do their work. But whenever they've tried to get back to their CrossFit, they've been painful, they've had a click, they're not being able to just do the same weights or the same intensity.
Or it feels unstable when they get to that sort of pressy position.
Exactly. So when they just come back and they're just about to load to push out, so there may well be an injury there, and it's a very subtle instability, and that can often be missed. And what happens is that the patients, will sort of self-diagnose themselves after consulting Professor Google, and on Google it will just say it's rotator cuff related pain. They may see some therapists who may not be particularly experienced with shoulders. Again, will say rotator cuff, pain, but actually they then go off, have a scan, and the scan says rotator cuff looks okay, and they're thinking, well, what is it? It's actually a problem deeper in the actual ball and socket joint, and it's a problem at the labrum, which is quite subtle.
And when we see those, we will talk about that. And going back to the very first point you made was about diagnosis. I mean, the management of that compared to a rotator cuff related pain is completely different. So
it's totally different.
That's why the diagnosis is so key. Okay, what about that's CrossFit, and that makes up a large percentage of shoulders that I see. I work with a few of the CrossFit gyms around Hertfordshire, and that's pretty common stuff that we see as well. What about rugby? So obviously we do some work with rugby as well, but I mean, rugby, obviously you get a few more kind of high trauma injuries, but what's kind of the typical rugby injury you see?
I mean, arguably the most common rugby injury that I see will be secondary to a dislocation. So patients got sort of gone down in a tackle or some sort of contact, and they've dislocated their shoulder. They've had to be taken off the pitch, may have gone to hospital, had it relocated, and that may have just been the first time, or it's happened now for second, third, fourth, and it's become a recurrent problem. And this is sort of quite a big issue in the sort of recreational rugby play at the weekend. and also sort of at professional level. And sometimes even sort of, the higher sort of the athlete, sometimes the more subtle the injury can cause an impact on their ability to perform at a high level. So there may be an athlete who, again, had a subluxation, which is a partial dislocation. They think they can carry on playing, but their shoulder's just not right.
Yeah.
And they may need a stabilization procedure to help get them back to the high level at which they're used to playing.
Yeah.
So dislocations are high. And as we know, the ball and socket joint in the shoulder is the most commonly dislocated large joint in the body.
Yeah.
And that is a common injury. I think other injuries which I often see related to rugby are AC joint injuries, where you have the joint at the end of the collar where it joins onto the shoulder tip, and some people can sprain it. They could have landed awkwardly on the shoulder, or it could be related to a tackle with a direct force onto the top of the shoulder. And occasionally players will dislocate that joint.
Yeah.
And if you go into sort of a Premiership sort of changing room, you'll often see a number of the players who've got their collarbones sort of sticking up, and the physio's taping them off, plenty of padding, plenty of tiger tape over the top to get them back out on the pitch. And some of those injuries require an operation, and some players tolerate them very well and manage to to sort of get away without an operation. And then of course you've got your usual tendon tears, sort of pectoralis tendon, rotator cuff tendon, or even sort of a fracture of the collarbone. I mean, you can just about get anything in rugby these days.
I'll tell you a funny story quickly about my own AC joint injury playing rugby. I had a very poor career of rugby. I was not very good at all. But I decided to make a glorious comeback after uni to go back and play. And I got picked in the Welwyn Rugby Club third team, and was told to play at flanker because last season's prop was actually starting at fly half that year. And I am not built like a flanker at all. Anyway, off the kickoff, the new club, thinking I was going to impress, trying to impress, and caught the ball off the kickoff, first game of the season, 3 seconds in, got clattered by some bloke, landed straight on my elbow, and felt a giant pop at the front of my shoulder. Knew straight away what I'd done, but I couldn't face coming off after 3 seconds in the third 15, just through pure embarrassment. And the next bloke who ran straight at me, I went to line him up and decided that it was better off I just let him go because it was going to hurt my shoulder. And he ran straight through me and scored a try. And that was the end of my rugby career.
Great way to sign off.
Yeah, I thought 3 minutes back, and that was me done. I was bored because I couldn't face getting hurt anymore. Okay, so that's rugby, silly game. What about cricket? I mean, cricket is something I work pretty closely with because that's my kind of main sport that I play. One of the things that we see probably the most in cricket is people who have general instability in throwing for various reasons. May or may not be traumatic with some of the kind of subluxations we were talking about before, but what are the kind of things cricketers?
Yeah, I think with the cricketers, again, tendons are very common, but one thing that I always particularly interesting is their sort of the range of movement and whether they're quite tight in internal rotation, or what we call a GERD, a glenohumeral internal rotation deficit. Because you'll get a lot of sort of throwing athletes who are quite, through repetitive stretching, are quite loose arms, but then conversely very tight at the back. And sometimes when you sort of check, they're just so tight that effectively they are changing their shoulder biomechanics, which can lead to the possibility of a more mechanical type impingement simply because they've got such a tight capsule. And I think what's sort of important from my point of view is to sort of try and spot things like that, because often, by the time they come to see me, they've got this idea that they're seeing a shoulder surgeon rather than a shoulder specialist. They've got this idea that I'm going to stick my camera inside their shoulder, give it a bit of a tidy up, make some more space, and everything will be better. When in actual fact, if we sort of then, if it's something that I can pick up, say as a GERD, which may or may not have been picked, well, I presume it's not been picked up before, then I would say to them, well, look, we need to work on this first. Have we thought about this? And I'll communicate that to their physiotherapist to say, look, is this an idea that we could sort of try and see if the patient gets better before we start the ball rolling? Because what's sort of important from my point of view is that if you do perform some sort of operation, the best chance of getting someone well is to get it right on the first occasion that you perform any surgery,
Yeah.
rather than say, okay, we've done one procedure, not quite right, or let's do another one, and then maybe another. That's not right. You want to get it right, spot on, first time. So I think looking at sort of, capsular tightness, particularly sort of at the back, tendon-related issues, it may just be sort of a bit of overload. Look in the history, have they sort of changed their bat, their grip, have they changed their sort of, bowling technique? There's all sorts of things which, quite often may have been overlooked at recreational level. Often if you're dealing with sort of professional teams, the sort of, team physiotherapist is not only being spot on, has already gone through all that kind of stuff already, and done video analysis on techniques, etc., etc.
Yeah.
But, again, that sort of instability, particularly with sort of, sort of a sort of throwing, could they have some sort of, sort of labral issue in their shoulder? These are all things to sort of look at in that kind of population. Yeah.
I fully agree with the whole GERD issue, or in reduced internal rotation. I mean, if you had to say anything, what's the go-to thing you do with most overhead athletes? The first thing we look at is that. I mean, it's the most common, and we're pretty repetitive with our messaging about how you've got to sort that movement out before we kind of kick on with the other stuff. And it's amazing just but even incorporating that into a warm-up, particularly in cricket, for example, we get some of the guys we work with just to keep working on internal rotation as part of their warm-up. And I mean, that is between them being able to throw the ball from the boundary and throw the ball from 15 meters away, just purely by normalizing the movement again. So sometimes in that situation, there's not actually a lot of input required. It just needs to change their management, change their program slightly, and point them in the right direction, and then they're normally okay. So cool.
And then anyone who does a high arc activity, such as sort of bowling, is to always think, could the AC joint be being irritated by repetitive high arc activity?
Yeah, and just complete repetitive kind of joint use. Okay, fine. So they're the kind of injuries. I mean, understandably, a lot of that stuff I see, we tend to see the people who don't end up as bad as some of those ones that you see, but very similar injuries. What about, okay, so if let's take like kind of three common ones we've talked about. How long would you say on average it takes? If someone asks me this question all the time, and I've got my own ideas about it, but how long do you think it takes someone to recover from a rotator cuff related pain? Let's call it, kind of keep it vague.
I would say sort of at least 3 months. Okay. And it's unusual for me to see somebody in clinic who's had symptoms for a shorter period than that. Obviously, so the patient sort of developed some sort of pain. They've probably gone through a phase of trying to do something themselves, looked it up on the internet, self-medicated with some ibuprofen, paracetamol, and then they've then gone to see their therapist. And that can be sort of a variable amount of time, depending at which point the therapist has said, look, I think you need to come and see Tony Corner and, try and work it out. We're not getting anywhere, we're not progressing here. And I think with most tendons, you don't deal in weeks, you deal in months. Whether that be, a rotator cuff related pain, someone who's had a rotator cuff repair, the recovery is months and months. Someone with a tennis elbow, majority of tendinopathies around the elbow will settle over the course of a year.
That's so true.
Whether or not someone is willing to actually go through the pain, the suffering, and the disability for a year, and that's often the problem. Is that patients want to get back to their lives and get back, and not be inhibited in their recreation and their work, for a short amount of period as possible.
We were talking about that with a patient of mine this week, actually, who had a tennis elbow. And we were saying I said to her, it's going to take you, we're staring down the barrel of kind of 12 weeks of this at the very minimum. And she was disappointed with the news because she believed just because it was a common injury meant that it should be able to be fixed quickly. And I think
Yes.
there is this conception that just because rotator cuff problems and elbow tendon problems like tennis elbow, golfer's elbow, just because they are common injuries, it doesn't make them get better any faster. These things take time. And that's because the tissue's got to go through change. You've got to load it again. You've got to offload what you're doing before, change technique in some scenarios. And I think there's this misconception about that. So it's good that you say that here, because there'll be people who listen to this who are frustrated kind of 8 weeks into a program with a physio and starting to think it's not working, but actually they kind of bang in the middle of,
Yeah.
of
But it's also important for me, because by the time a patient comes to see me, if I know they've had a good run at the physiotherapy, then I don't need to think, well, hang on a minute, this patient may get better if we give them sort of a bit longer. You see, they've already sort of exhausted that. And then I think, okay, we've sort of ticked that box. Maybe we need to start moving on to something else now.
It's so true. And that's something we kind of reiterate as well. Even we'll get people come in and say from day one, they'll say, so I've got the shoulder problem. I've tried a few exercises from one of the physios who saw me in the GP clinic, and he gave me a few stretches and didn't really work. So basically, I've been told I could come and see you for a second opinion. And I'll say, look, it's going to take 3 or 4 months. And they go, I've already tried physio. Do you reckon I'll need to see the surgeon? And you say, look, you may need to see a surgeon. Generally speaking, you won't, but you may. But also, it's a hard one, isn't it? Because you have to be like, look, with all due respect, a couple of stretches you found on Google and a one-off session with the physio who gave you a sheet of exercises to do is really not proper rehab. That's really not what we're talking about. We're talking about a very structured minimum 3-month program about how to actually strengthen that tendon in a very specific way.
Absolutely. It's key. And that's why I always ask, what kind of physiotherapy have you had so far?
A few stretches, bit of ultrasound, didn't work.
It didn't work. Sort of, I was beating my shoulder with some, sort of branch, and it's just absolutely rubbish.
Exactly. It has to be it has to just be the right stuff. Okay, fine. What would you say if we if you had to say then, what is your, I don't know, top 1 or 2 things, bit of advice that you would give to a patient in terms of the biggest bang for their buck for shoulder prevention? If someone's listening to this who hasn't got shoulder pain, let's say they're a CrossFit athlete who trains a lot, and they've just heard you and me talk about how common rotator cuff problems are in CrossFit athletes, what's the biggest advice you give?
I think the biggest advice, and I think this applies to CrossFit and just about any sort of activity or sport, is to use your shoulder. Lots of people would try and rest, but I think it's much better to sort of use it, try and get it strong, but do things in a gradual fashion so that you progressively load. Don't do things too quickly, just progressively load, keep exercising and get things strong. Okay. If you stop using things, then they will only get worse in the long term. Okay. And I always sort of, as a general philosophy, encourage my patients to exercise. Use it or lose it. You'll be exercising in your 20s to get your beach body. You'll try in your 30s to keep your beach body. In your 40s, you're fighting a losing battle, really, as I'm discovering. And then you're exercising in your 50s because you're still doing the sport and you still think you've got it. But actually, you're also laying the foundations that in your 60s, you're still pretty active and pretty decent. So that in your 70s, you're independent. You're not using sticks. You're not using frames. You've still got some core muscle. I just think throughout your life, it is a good philosophy to exercise, full stop. And when it comes to sort of sports, again, build things up gradually. If someone's just starting out, don't just suddenly, go down to the gym without any training or any idea of how to use the weights and the machines properly. Get a trainer, get someone to show you how to do things properly, because you will also get much better results. I don't want to sound like a personal trainer. I'm not a personal trainer, but making sure you're in the right position, in order to perform a said activity or exercise is really important, because that will also help prevent injury, but also help you get the most out of what you're actually doing.
Actually better. We say that a lot to people. It's not you know, if you fix this problem with your movement, or let's say range of movement, it's not just going to allow you to get rid of your pain. You'll actually become a better athlete for it.
Yeah, I mean, you know, a lot of bodybuilders will have taken time away from doing heavy weights and just spend a long period of time just doing core,
Yeah.
because there will come a point where if they haven't got a certain core, they simply will not be able to lift the massive weights that they ultimately want to get to.
Yeah.
You know, you've got to lay the foundations.
Yeah, for sure. I mean, that's pretty much what we advise as well. We're passionate and, you know, pretty structured with strengthening and movement. I mean, one of the things I can't remember where I saw it. There was a study a few years ago that basically pointed towards resistance training reduced mortality risk by all causes.
Yeah.
You know, and so, you know, we're big advocates of it, and we work very closely with those of you who would have been to our practice would have worked with Freya or Jamie or one of the other physios or strength and conditioning coaches that we work with on site, because we very much believe that it's an approach that, yeah, okay, we can get you so far. We've got good people who can get you further, and it's, you know, it should be part of every program, really, as far as I'm concerned. I think nowadays, I think in this day and age, yeah, there's probably a lot of physios that, you know, my profession at the moment, I believe, is quite divided in terms of their opinion on management of these things. But I really think that nowadays, if a physio is not giving you a proper strengthening program, or at least advising you to see someone who can, I think they're letting you down if you've got a tendon problem.
Yeah, exactly. For tendon-related issues, you need to be doing some sort of strengthening ultimately.
Yeah.
There may just be some patients who, for example, may have a symptomatic rotator cuff tear, and I specifically say a symptomatic rotator cuff tear, which is another question in itself. What makes a symptomatic rotator cuff tear versus just a rotator cuff tear, which happens to be there anyway?
Yeah.
But you know, there will be some people who are and weakness. And their shoulder has not compensated for that rotator cuff tear, and they do benefit from having a rotator cuff repair. But remember, rotator cuff tears are quite common, especially the more elderly we get, and we don't repair everybody's rotator cuffs.
And also, importantly, on that point, there are elderly people who have a full rotator cuff tear who are completely functional and pain-free.
Absolutely.
And that's an important point.
Absolutely. And I think in the wonderful world of rotator cuff tears, the size of the tear doesn't necessarily correlate with the level of pain that a patient may actually be presenting with.
Yeah.
I think everybody's different, and it's something we don't particularly understand. I've seen patients who had a bit of a niggle in their shoulder. They went off, they got sent for an ultrasound scan by the GP, massive tear. They then come to clinic and they said, I've been asked to come see you because I've got a massive tear. I say, well, what problems have you got? Well, I did have a niggle at the time, but it actually feels a bit better now.
Yeah.
I say, well, show me what you can do. And the other arm straight up in the air and say, can you do all the things you want to do? And they go, well, yeah, fine. But I've got a massive tear. And I go, look, I think we just had the easiest consultation of the week.
Yeah.
Just go. Your shoulder has compensated. But then there'll be some people who will have a lot of dreadful pain, like a toothache in their shoulder that just doesn't go away. They can't find a comfortable position. It's waking them up at night time. Their shoulder's weak, and and it's just upset the apple cart. And those patients who then haven't got better with the rotator cuff strengthening, anterior deltoid strengthening exercises may well benefit from a rotator cuff repair, which fortunately, if you get the right patients, can do very well indeed.
Yeah, no, that's great. Okay, last couple of questions, Tony. I won't keep you for much longer. I've kept you for ages.
That's all right, mate. We're talking shoulders. I could go all night.
I know. I realise I'm on a passion project, but also for myself, I could talk about this forever. When should someone see you or me or a GP? What would you kind of say? I mean, I've got my opinions on how that process works, but what would you say is the pathway?
I think sort of if someone's got a traumatic injury, I think that's a good one for me to see acutely.
Yeah.
To sort of delineate what the traumatic injury is, because invariably, if the patient's had a traumatic injury, so an acute, clear traumatic event, they will most likely need some sort of imaging, and I can arrange the correct imaging. We can get the right diagnosis, see exactly what's wrong, and then have a good discussion regarding non-operative versus operative management, and then say, great, you need to go and see Rhys and Jamie and the team over and follow that path. Or maybe somebody say, well, hang on a minute, no, this is something where we know from the evidence you would do better with an early operation to repair that structure. And then we can get on with it. And then you don't risk the patient going through a period of rehab and then presenting late when it's even more to try and get the problem fixed. I think patients with a more chronic problem, I've had shoulder pain for the last sort of 3 months. I think that's where a lot of patients will go and see their physiotherapists first, as a first port of call. A lot of patients have already got a relationship with their physiotherapist. They'll go and see them. They may have had some sort of treatment on another part of their body before by that physiotherapy team, and and they get opinion, and that's absolutely fine. And a good physiotherapist will probably try and work out whether it's rotator cuff related or more potentially a frozen shoulder if it's stiff as well as painful. And then if the patient's not getting better with that initial period of therapy, then they can come and see me, and then we can say, okay, I always just take a fresh look and say, okay, what is the diagnosis that we're working on? Try and get that right first, see what treatments happened so far, work out what's next on the menu, and what the options are for the patients. So I think a lot of the time, the patients, yes, some patients will go and see their GP, they've got a good relationship, but a lot of the time with musculoskeletal issues, seeing their physiotherapist, or if it's something more acute, coming to see their surgeon first, I think will probably be a better way around of doing it. Certainly having that access to do that in the private sector, I think in the health service, that's obviously a lot more tricky.
A bit more tricky, yeah. I mean, I think now, for what we do, I mean, really, if you take that person you just said a minute ago, the kind of 3-month history of chronic shoulder pain, not really getting better, not really getting worse. I mean, generally speaking, physios get a pretty good result with that. So, the majority can be sorted conservatively without ever needing to see guys like yourself. And I would say, obviously this is a very biased opinion from a physio, but I would say that, as you said, the vast majority of musculoskeletal pain is very much, physios are well placed to diagnose that in the community setting. Let's say they haven't got access to people like yourself as a kind of first port of call. Most physios, particularly in private practice, I can speak from private practice perspective, have a pretty good idea of what's going on with most musculoskeletal issues. And without kind of meaning to kind of digress too much, with some of the GPs, I think sometimes the diagnoses are a bit wishy-washy, and sometimes they do well for pain relief, but if in terms of the rehab and strengthening conditioning, I do think that you are best placed seeing someone like myself or a physio who can at least point in the right direction of that if the pain is settling but you're still not where you need to be.
I think that the physiotherapist is a great first point of call. And what often happens is that sometimes the physiotherapist may not be quite sure, have we got the right diagnosis here?
Yeah.
The patient comes to see me, I'll sort of check the patient over, arrange appropriate imaging, correlate the imaging with the patient, and then actually just say, okay, yes, we're on the right lines. I've excluded a number of other causes. Just keep at it.
Yeah, keep going back.
And I think that's the important thing, is that even sort of whichever way the patient starts off with the physiotherapist, or potentially sort of a shoulder surgeon, shoulder specialist like myself, ultimately you end up working very collaboratively together further down the line anyway.
Yeah, no, I mean, that's a good point. We generally we have a pretty solid pathway about when do we need to actually refer this on, and when do we not? When do we just need to be persistent and take our time? And I think that's the beauty of that relationship. And we're lucky we work quite closely together. But for a lot of physios, they should have a good network of people that they can refer into, who can then refer back into, and work quite collaboratively together to kind of get.
I think you need to have your go-to person, and I think what's crucial in medicine is communication with your patients, that you explain things sort of correctly, that the patient feels they can ask anything they want to ask, so that you've got a really good communication channel with your patient, but then also have the right communication with the people you're also working with. For example, the surgeon with the physiotherapist, etc. Everyone's all got to be sort of on the same page, and it's a very, very important skill to have.
Tony, that's super useful. Thank you very much. Okay, last question then. If someone did want to see you, people who listen to this probably know who we are, but if not, I can link it to our website. Our website is carterandgeorge.co.uk, and actually on our Instagram account, there's a lot of kind of useful videos and stuff for some of the exercises and things that we've talked about on this call.
Yep.
But if someone wants to get in touch with you and see you, what's the best procedure?
So I consult in 3 places. I consult in Harpenden at Spire Harpenden Hospital. I consult in Bushey at the Spire Bushey Diagnostic Centre, and also in Hemel Hempstead at the One Stop Doctors Healthcare Private Centre.
Yeah.
And the patients can either contact either of those locations to book an appointment with me, or contact my secretary who has an appointment for them. And all the details are on my website, which is tcshoulderelbowclinic.com.
Yeah.
And my secretary's details are all there, and the patients can make the necessary appointments, and I'm available each day.
Yeah.
And that's, the best way of getting in. With regards to my website, there's a number of articles on the website based on shoulder and elbow, both what the conditions are, what procedures can be done. And it's all sort of written not really for a professional to feel thoroughly educated on shoulder and elbow problems, but it's written in patient-friendly language, because we all know that patients often forget the majority of what's just been said during a consultation. And I think it's useful for them to have a resource that they can go to help sort of jog their memory, to just try and reinforce what we've tried to explain in the clinic scenario.
Yeah.
The other thing which is on my website is that I have a section on post-operative rehab protocols.
Nice.
So wherever a patient's had their surgery, and I operate in all 3 institutions, the patients themselves and their physiotherapist can then go to my website and download the rehab protocols as a PDF document to use as a guide. So it's not hard rules, but use it as a guide to show what kind of things to do, and what are the sort of time points for achieving the various targets in the rehabilitation following any operation that they've had. Yeah. And that has actually, over the course of time, been by far and away the most popular part of the website, actually.
Yeah, no, it's super useful. Even, to be fair, I go on there quite a lot to check out some of the protocol, make sure I'm following the right plan. Yeah. And just to double check, if people do want to see, obviously you consult privately with kind of point of service payments. People can pay you to see you, but also you use that. And
so basically, I'm sort of I have agreements with all the major insurers, and also obviously patients can self-fund. All the sort of the details of which will be sent to patients when they book an appointment, and I hold these clinics at Spire Harpenden, Spire Bushey, and One Stop Doctors in Hemel Hempstead, where I can conduct face-to-face consultations, and also, if it's appropriate, sort of telemedicine consultations as well, which has obviously been very useful during recent times during the COVID crisis.
Moving with the times in 2020.
Who'd have thought a surgeon moving with the times?
Right, unbelievable. Right, Tony, that is brilliant. Thank you very, very much for that. Hopefully people listening to this find it super useful, and catch up soon.
All right.
That's fine. Cheers, Tony.
All right.